Assalamu alaikum wa rahmatullahi wa barakatuh. So today, inshallah, I will be speaker, and now I became chair. So I would like to thank Novartis before everything that they gave us the chance to present our data in Saudi Arabia, or let's say in our cohort in King Saud University. Then I will take the 5 minutes to present few cases. As you know, this satellite symposium powered by Novartis, and I will talk mainly about secukinumab in my presentation. But seriously, I am very proud to introduce our superstar, third-year student, Dr. Rema Al Rashed. She is the one who made our registry or cohort walking very fast or running. We started about 2 years ago. At that time, she was a third-year student. Now she is fifth year, and I give her the chance to present our data within 5 minutes. So please, Dr. Rema.
Good morning, everyone. My name is Rema Al Rashed. I'm a senior medical student at King Saud University. Before I will start, I would like to thank my research team and especially my supervisor, Dr. Mohammed Bidawi, and the organizing committee for such a successful event. So our aim of this presentation is to have a description of our spondyloarthritis patients in a local center and to build a connection to establish local cohort and hopefully in the future to have Saudi registry. As we can see here that all over the world there are multiple registries. However, our kingdom is lacking this. This raises two questions. Where are we in a place and time? And what's our future plan? Our study is an observational prospective cohort, started 2017 and ended in 2019. We evaluated patients' demographical data and clinical characteristics of patients and patients' reported outcome. Here we included 106 patients. They were all adults. And those who met the modified New York criteria of ankylosing spondylitis were defined as ankylosing spondylitis, and there were 49 patients, and those who didn't meet the criteria were defined as a non-geographic axial spondyloarthritis, and there were 57 patients. Okay, so out of 57 non-radiographic axial spondyloarthritis, 92 were Saudi, and for ankylosing spondylitis, 87% were Saudi. Here we can see the general characteristics of our patients. Males were 57 and females 49. The mean age was 39, and the mean age of the symptoms were about 13 years, and the disease duration was 7 years. And this kind of giving us an idea about the gap between the delay of the diagnosis and the start of the symptoms. And most of the BMI were overweight, about 27. Okay. So those who had positive HLA-B27 were 64%, and those who had positive family history were 12%. And we classified patients according to their used medications. Those who used NSAIDs only were 11%. Those who used biological DMARDs were 74%, and those who used conventional DMARDs were 22%. And here, as we can see, the comorbidities, the most prevalent comorbidity was hypercholesterolemia, 24%. As we can see here, there's a comparison between the Saudi general population and our patients. We found that the comorbidities is less prevalent in our sample. Of course, they are younger in age. So here is the relation between CRB levels and the prevalence of comorbidities. We found that those who had higher CRB levels were having higher BMI. And here we see that age is a risk factor for developing, of course, fatty liver, depression, osteoporosis, osteoarthritis, and hypertension. For reporting history of extra-articular manifestations, the most prevalent extra-articular manifestation is uveitis, and it was prevalent as 30%. Psoriasis 13%, and Crohn's and colitis was 8%, and it was more prevalent in non-radiographic axial spondyloarthritis. For us, most of our patients, or the majority, were having low disease activity, about 31%, and those who had a very high disease activity were 15%. And the mean score was 2.3. Our ongoing data analysis is patient-reported data, the modified stock of ankylosing spondylitis, spinal measurement, dactylitis, enthesitis, and drug intolerance. That's it. Thank you.